Good afternoon, dear colleagues. Welcome. Our purpose is have a challenge discussion on the topic how to treat chronic urticaria when omalizumab is not an option. Let me take a moment to introduce myself. My name is Dr. Cherrez-Ojeda. I am a pulmonologist, allergist, and a doctor in research. I am the director of UCARE and Care Center at Respiralab Research Center, Kennedy Hospital. I'm a research professor at the University Espírito Santo in Guayaquil, Ecuador. A number of UCARE projects have been developed by us, including Curie, Promuse, and Sleep CU. It is an honor for me to introduce our faculty member today. I would like to start with Dr. Jason Falk. Dr. Falk is an allergist, immunologist, and internal medicine physician based in Melbourne, Australia. He runs an immunology allergy service at Box Hill Hospital in Melbourne with a special interest in all forms of urticaria, hereditary angioedema, anaphylaxis, and drugs allergy. He is also the director of UCARE and Care Center at Box Hill Hospital. He is regularly invited to speak at allergy immunology meetings in the Asian Pacific region on topics such as chronic urticaria, angioedema, hereditary, and perioperatory anaphylaxis. Good afternoon, Jason. Welcome. It's my pleasure to welcome Dr. Caroline Vera today. Dr. Vera is a dermatology and allergology resident in Charité University of Medicine, Berlin, in the group of Professor Marcus, a member of the UCARE and Care team of Berlin, with a clinical research interest in mast cell-related diseases and hereditary angioedema, head of group Biobank. Hello, Carol, welcome.
Hi, thank you.
Last but not least, I would like to welcome Dr. Guilherme Azizi, immunologist, immunology mastering with them in cholinergic urticaria from Federal University of Rio de Janeiro. This is all of the faculty. Please allow me to provide some information regarding the UCARE LevelUp program. In our interactive meeting, we provide update of guidelines, new diagnostic tools, and update treatment algorithms. We also discuss challenging situations when dealing with patients with chronic urticaria. A number of activities will be offered as part of this educational program for physicians in order to increase their awareness and knowledge of chronic urticaria. It's very exciting for us to see the people from many countries participating in today's fireside chats. Let's begin with this conversation. And the final of the webinar, you have a survey. We will appreciate your feedback. Thank you. We start with this faculty. I would like to talk with you on the first of all, how is omalizumab available in your country? It is easy to access.
Thank you for the introduction, Ivan. My name is Jason from Australia. I'm based in Melbourne. So in Australia, omalizumab is available for various indications in Australia for asthma and obviously for chronic spontaneous urticaria as well. So there's a certain guidelines that we follow in Australia. Before a patient is eligible for access for omalizumab, we tend to, the patient would have been started on second generation antihistamine, starting from single dose up to fourfold increment, together with concurrent H2 antihistamine, obviously together with careful documentations of UAE7. Before omalizumab is actually granted to be used for the individual. Yeah. And it can be prescribed by immunologists, allergists, and dermatologists in Australia.
Yeah, perfect. Carolina?
Yeah, so here in Berlin, we do something similar as in Australia. We start with the patients, we give a second generation antihistamines from 1-fold to 4-fold. And when that doesn't work, then we give the patient either the option to join a study, or they can start with omalizumab. And when omalizumab doesn't work, then we also give again the option to go back to the studies.
Okay.
Yeah.
Guilherme, now we are talking about South America. We are in a different situation probably. Guilherme, talk to about this.
I'm Guilherme. I'm a master degree in the culinary care that I introduced. And I thank you, Eva, for this. Thank you for the invite. And the South America is so different. It's like I speak to you, but in Brazil you have a many states, the many locations. It is so different. The access it is so different. Understand depends to the state, but I can speak about the Rio de Janeiro. It's a state in Brazil. It's my state. It's my province. And in my location, in all the Brazil, you have a public health system, and omalizumab is used as asthma and urticaria, chronic urticaria, like on all the world. But it's not the same for you assess the medication. In Rio de Janeiro, I can do in my university same, that's Carolina and Jason and you, Ivan, and started to the second generation to antihistamine, and after that you up dosing to antihistamine after add to the 40, and after that you can introduce the omalizumab. Now you have another options to studies to invite the patient, but the sequence is antihistamine, and after that omalizumab, and other things that you will speak after that about the omalizumab. And if the omalizumab is you have a poor response to omalizumab, you can start or tend for the cyclosporine. It's like a guideline, it's like a consensus that you know. But the access in the Brazil, you have two options for omalizumab. You have the public health, and you have secret health. And the public health, you need to create a document and invite to the judge, and looking for the omalizumab for this. And the secret health, it's you have a permutation in Brazil today to have we have a more access for that, and it's more easy. But in public health, it's so strange. It's so we can waiting for some months, 6 months, and 3 months for the medication, and it's so problem for the patient. That's it.
Oh, listen to all of you. I am envious of you because my public health and some private health do not provide omalizumab in my country. This is a huge problem in low-income countries because it's sometimes we have in front of us the patient who say, please, doctor, help me with the medication. It's a huge problem for us because the public health, the patient need to pay their treatment in most of our patient in our country. This is different situation, and we need to think in another kind of treatment. And I hope to talk with you and after of our session. Okay, it's good, interesting concept. I don't know, what do you prefer? I am thinking when you don't have a good response with omalizumab, what do? You increase the dose?
So maybe I can read one of the questions or comments that we get right now at the box, which comes right into the topic you want to comment.
Okay.
This is a patient who says her IgE level is 41. Her C2 and C3 are negative, and her ANA antibodies are also negative, and the rest of her blood work is in normal range. She has been taking 300 milligrams from omalizumab per month for the last 6 months, but she doesn't see any improvement, and she asks how long should she wait, or what could she do? So maybe you could start answering, Ivan. What would you recommend in this case? She has been taking, her IgE is 41. She has been taking Xolair, but she doesn't see an improvement. What could we do?
41 second number is.
Sorry.
I think from the data we know the omalizumab is very is effective. Yeah, it's most effective at the dose of 300 milligram every 4 weeks. And we know from previous study, about 36% or 38%, achieve complete response. And it has been demonstrated in various studies that patient reports improved quality of life as well as improved sleep in various studies in recent years. I think based on my personal experience, the expected response to omalizumab, majority of the patients will report some kind of improvement by the 3rd dose, which corresponds to probably about the week 12 mark. Yeah. So I think by and large, about 40 to 50% of patients, they become asymptomatic by week 12. And probably, by the end of 24 weeks, which is probably the 5th and the 6th dose mark, almost half of them, will have achieved kind of a remission. I would say just looking at that based on past experience, and I think overall 16 weeks to 18 weeks should be sufficient to identify who actually will benefit from omalizumab. Yeah, that's my personal experience. Yeah, but happy to hear from the floor.
Yes, we wait for 3 months, but I guess the most important sometimes to have in our mind is how to measure a good response. What kind of patient-reported outcome do you use? Because sometimes you can use, for example, urticaria control test or UA7 or quality of life. We are trying to writing something because sometimes you don't have exactly the response that the guidelines suggested. For example, have a 0 UA7. Okay. However, when we look all of the subdomains of the, for example, quality of life, surprisingly, you have patients who had a good response of different domains. For example, sleep, the people have more comfortable, the people are going to work again, the people have less problem of the anxiety. And sometimes we think that the omalizumab doesn't work. I need to look very, you need to look all of the subdomains of the patient-reported outcomes, and we wait 3 months. If the patient doesn't respond for 3 months, we increase the doses or short the interval. And the huge problem for our situation is the patient sometimes don't have money for this. And in this case, we have choose, for example, use cyclosporine, because there is a 2 interesting paper published recently, one for Emek Kordakup, and she mixed omalizumab with cyclosporine, and their chance of response in this case is similar to Professor Jorge Sanchez from Colombia. Sometimes we think the question is, you increase the dose, you choose for cyclosporine, you mix all of this, and we need to think that it's probably could be a good idea to choose omalizumab with cyclosporine.
Yeah, So we recommend here at least 6 months of treatment with OMA before we change to other options. No. I have a second question here from Luis Encina from Brazil. He is asking, for situations where OMA is not an option, is worth trying higher than 4-fold dose of second antihistamine generation associated to also to a first generation antihistamine? Do you do that in Ecuador or in Brazil, that you mix H1 with H2 antihistamines?
Will you repeat, because I lost?
Sorry.
Yeah. No, it's not a problem with my internet.
Do you in Ecuador combine first generation, so H1 antihistamines with H2 antihistamines?
Yeah, this is a good question, a very important question, because when we read all of the guidelines say don't use first generation of amphetamine because a lot of problem. Okay, is good. However, in our patient, a lot of patients, we need to use the first generation at night because it's cheaper, very cheaper. For example, if we increase 4 doses of second generation, our patient needs approximately $10 per day.
Mm-hmm.
The people receive the salary, the best salary is $400, and think about our patient don't have money, and we lose some time to improve them. We mix, really, we are talking about real life, and we sometimes, it's not frequently, but sometimes we need to use the first generation. We prefer to use at night. I remember a paper 15 years ago, Professor Kaplan wrote about the first 10,000 chronic urticaria. He was published in JCI. And his experience, he only found 10% of patients have problem with the sleep. I remember this paper, and in the practice, for us, no problem to use in first generation. It's not frequently, but we have in our treatment this possibility. Probably Marcus caught my hand, but is that real?
It's everything depends on what we have available. No, here we have a lot of options, and that would be something that we live for when we don't have any more options. No. Talking of another option, what things are to be considered when we indicate cyclosporin? Do we stop OMA directly? Do we mix it or combine it with cyclosporin? And I have another question here about cyclosporin. Is cyclosporin a better immune modulator as methotrexate or azathioprine for the use of urticaria, for the treatment of urticaria? Maybe Ivan or Jason would like to start.
I am excited with this question, but I prefer to Jason start or Guilherme because I wait.
I'll share from my perspective. I think in Australia, once we start prescribing omalizumab, we can get a 6-month script before we renew for the next script. So I think in my experience, all of my patients so far, they have responded quite well on omalizumab. Yeah, and we tend to just continue the omalizumab for 1 year before we consider down dosing treatment. And in my experience, some of the patients who haven't actually achieved good remission or good symptomatic control, despite on 300 milligram of omalizumab every 4 weeks, we have the options of updosing omalizumab, to 450 and then slowly up to 600 milligram every 4 weeks before we decide whether or not the patient is actually a good candidate, for long-term omalizumab. So in that regards, in our center, in our hospital, we've been focusing mainly on omalizumab in treating recalcitrant CSU in terms of updosing? Yeah.
For this question, there is a recent paper. I am always a lucky man. Recently, there is a network meta-analysis. This professor from Taiwan, he combined omalizumab with all of the another immunosuppression drugs, and they explore methotrexate, cyclosporine, and the answer for methotrexate is not good because it's similar to placebo studies to compare omalizumab with azathioprine or cyclosporine, but he used a network meta-analysis. It's a different kind of statistic programs. I'm using that. Omalizumab is the best. Second, we have a good response for cyclosporine, but with methotrexate, it's not good. But this is an answer for this question. And we prefer to combine omalizumab with cyclosporine. We are decreasing the doses of omalizumab. We have always remember a paper probably publicated, I guess, 4 years ago. They use 3 milligrams per kilo per day, and you prefer to use this dose because it's better for a long time response.
Here, and it's my work. Here it's a similar, but we can use no more the other immunomodulators like methotrexate or azathioprine. Use only the cyclosporine. It's not another step in the updosing, but you can use updosing to antihistamines. It's more to the 4 doses per day, and after that you can indicate omalizumab. And if the omalizumab is not, you have the patient have a poor response, you can waiting 6 months, and in the 6th month you can analyze its autoimmunity. It's the patient have the levels EG. It's like a 40. It's more 40. It's so difficult because the many patients have a more than 40 levels for EJ. It's a good response to the omalizumab, but if the patient don't have these 40 levels, it's a poor levels to the 40, or the patient have a hypothyroidism or other autoimmunity. You can in my hospital associate the cyclosporine with the OMA and create of these doses. It's so similar doses, like 3 at 5 milligrams kilograms per day, and it's so more fast. And in 1 month and 2 months, the patient create a remission. You can low doses for 2 milligrams kilograms or 1 milligrams kilograms, and after that you can stop the cyclosporine. And is a sequence that we can do here, because you can continue and maintain the sequence about the guideline all the time, because you have some problems to assess the OMA and assess the cyclosporine too, because it's so written here, and because I can maintain the sequence and add cyclosporine to OMA if it's possible, or updosing the OMA if the patient have a poor response, like you have a response, but 3 weeks after the administrative dosing, you appear on new wheels, and with create a new wheels, you can short the dose and create 300 milligrams, like 3 in 3 weeks or 2 in 2 weeks for a shorter time, because it have a same and a good response. If the patient it's all poor constantly, in the 6 months you don't have any response to the trauma, you can change all the treatment and was to the cyclosporine, and you started cyclosporine 3 and 5 milligrams 2 kilograms, and it's a good response. In my experience, to my hospital, it's a good response to the cyclosporine. You cannot use the azathioprine or methotrexate. You use the cyclosporine in sequence.
How long?
So how long will you continue? Sorry, yeah.
We were asking the same question.
More fast as possible.
To ask how long you will stay. Yeah. Okay.
More fast as possible, because the alters the cyclosporine creatine kidneys and liver and the other things. More fast, and the patients present remission, you can slow doses for that. You can slow dose from. And other thing that you use here, but it's for the delay pressure, is Depson. And in delay pressure, you can use Depson, and you have a good response.
Carol, I talking about this kind of Dapsone. We use hydroxychloroquine in our patient. Okay, we had experience using in urticaria vasculitis. We use hydroxychloroquine, and when we don't have patient have money to pay omalizumab, we use hydroxychloroquine. Recently, there is a publication for the group of Bernstein, and they show us that approximately the 2/3 of patients respond to hydroxychloroquine.
And how long do you have to give hydroxychloroquine to start seeing an effect?
Yes, the good, we need to wait 3 months to expect a good response. That is the problem. But we need to wait to continue using for 1 year. After 1 year, you have a good response. Approximately 66% of the patients have a good response.
Good.
What happened if you stop hydroxychloroquine? What sort of percentage of patients go into remission, and how many of them will get a relapse?
The patient, when you stop, we always continue looking for patient-reported outcome. In all of our patients with chronic urticaria, we check off a month, all of a month, and we know at the moment when the patient-reported outcomes change. And in this moment, we start again. We don't have a huge of patients. I don't have the number exactly, but approximately 50% of our patients have a relapse during the next 3 months.
50% in the next 3 months.
50% of our patients have problem after 3 months. It's similar when we're using omalizumab, how we need to try to use in our patient. We are looking for how the modification of patient-reported outcomes, and sometimes we put 1 dose of omalizumab, wait for 2 or 3 months, and the people feel good because they don't have money for buy omalizumab each 3 months, for example. Okay. It's not in nobody study this situation. There is no paper. It's only real life experience of our group.
So do you start hydroxychloroquine as a single agent, or do you combine with another agent such as Dapsone or sulfasalazine? Yeah.
No, I don't have experience with sulfasalazine. Only hydroxychloroquine, because we have a lot of experience using that.
Okay.
Thank you.
Yeah, we have another question from the chat. In places where access to omalizumab is limited, do you think IgE levels should be used to decide which patients received OMA? If there is high level, I think Guilherme, you were talking, but you were muted, so we didn't hear you.
No, it's a good question, because it's a so question that I create all the time and all day for this, because with the patient don't have this possible, it's not possible you can do OMA that. The autoimmunity, I think that the autoimmunity, it's so that all the professors use for this decision, because the patient have a vasculitis. If the patient have a hyperthyroidism or other autoimmunity, it's most possible you can similar like azathioprine or hydroxychloroquine, but it's a good question, and I have questions too.
What about you, Ivan?
I think it's a good question, but for us, there is not now a perfect biomarker. Okay,
Yeah.
you say if the patient have high level, okay, we have a good response, but sometimes patient with low level is not respond immediately. These are late responses, and we have chance for 6 months. I guess we need to use 6 months to omalizumab. In our patient, I don't have chance to increase the dose more than recommended because the people don't have money. But I need to wait 6 months. Sometimes I combine with hydroxychloroquine or cyclosporine, depending on the situation, or continue using antihistamine, because now our experience is to explore all of the patient-reported outcomes. We use the 3 principal patient-reported outcomes, and we found, for example, in the subdomain of chronic urticaria quality of life, we have good situation. It's similar to the urticaria control test. I may say to the patient, and the patient told us, "Doctor, I am feel good." But when we try to explain to the insurance, private insurance, that we need to continue using, sometimes have this problem because the people say, "No, it's not correct, it's not the guidelines say," but the people feel good. We use this biomarker, but sometimes we need to wait for 6 months.
Okay.
How about compassionate supply? You know, if there's difficulty in accessing omalizumab, is compassionate, supply an option?
I think that goes to either Ivan or Guilherme that are in Latin America. If the patients are, could you repeat the question again, Jason, please?
Yeah, I was just thinking, sometimes, because obviously omalizumab sometimes can be difficult to access in public health, is compassionate access an option?
We don't have this chance in our country because there is a lot of rules.
Rules and regulations.
During the last approximately, 10 years, they don't have chance for our public health.
Okay.
No, we can continue. You continue with the antihistamine and continue solicit to the health public the OMA at the time.
Yeah.
I personally will continue antihistamine as well. Yeah.
All the time.
In addition to the omalizumab. Yeah.
Yes, it's both with omalizumab, but it's when you're waiting the OMA, you can continue the antihistamine with the 4 doses, and if the patient has a crisis with a big crisis, you can put a little short with corticosteroids, and after that, with the 3 on 5 days, and after that, you can stop that and wait in the OMA, because the OMA it's a good remission for us. It's a good medication for remission, and when you receive the OMA, it's and the time it's so better that in the past we can receive the OMA, the patient receive the OMA, but the public health is so complicated because you have the same levels to stop this, and sometimes the government is speaking it's not more possible. You can receive the OMA. It's that, and the patients stay with without the medication.
So I will read again some questions from the chat. Greeting from Iran. Hello. She asked. She has a patient that is controlled under cyclosporine, and she's actually right now at the moment with a doses of 50 milligrams per day. And every time they try to discontinue cyclosporine, the symptoms return. What can she do to reduce the cyclosporine doses, and how should she do it?
I suppose that omalizumab, it doesn't work in this case, in this patient, okay? And I remember a good word that say, Guilherme, we need to continue using during the patient needed. When we read a paper, I guess from Israel, I don't remember, but they used for 5 and 10 years. I remember this paper because I say, wow, there's a lot of years using cyclosporine. If you have problem with the cyclosporine for side effects, hypertension, nephrotoxicity, okay, I recommend it to combine with hydroxychloroquine. It's a good drug. Or I don't experience with Dapsone. I remember we used Dapsone when I was young, but now Dapsone could be a good option. But I'm very safe using hydroxychloroquine.
Another question is from Emek. She says, congratulations on the great discussion and greetings to all of you. We literally need good biomarkers and endotyping of urticaria, that's for sure. Type 2B autoimmune urticaria may reflect with low levels IgE, high CRP levels, positive anti-TPO, positive ANA, and eosinopenia. Then spending long time over 6 months on OMA is not needed. Best is to skip and add cyclosporine for patients who are rich on neutrophils in the biopsies. Then we can think of Dapsone or hydrochloroquine as a...
Thank you, Meg. This is a good topic for us.
Yeah, I think it's a great comment because we know that Dapsone actually interferes or release or function of neutrophil lysosomal enzymes. Yeah, so it really knowing the endotype or nowadays we talk about precision medicine. Knowing the endotype of specific disease will really guide us in future management with very targeted treatment. Yeah, so it's a great comment. Thank you. Yeah.
Yeah, and we have one last question here. A patient that has it's not responsive to fourfold antihistamines and a low IgE started receiving OMA, but 2 days after receiving OMA, her symptoms worsened and got severe. What should we do? Do we wait to 6 months or do we stop? What do you do?
I think this can happen. Sometimes, exacerbations of underlying hives can happen while starting a new medication like omalizumab. Perhaps, adding antihistamines on top of omalizumab will be helpful, but I personally will give chance to for some time before we know omalizumab works or not. Yeah.
In this kind of patient, I use antihistamine. I use a cycle of corticosteroid. You need no problem to use this. You have more chance to the omalizumab work.
Guilherme?
It's a so strange case. You need looking for any others autoimmunity like too, and I agree like Ivan, it's so possible, but it's not continuous the corticosteroid like a long time. But I agree that in UCARE that you do in a hospital.
Yeah. I think it's also important to recognize to what extent the hives happen, whether or not there's other concurrent allergic symptoms, because we know very rarely, which has been reported in the literature, people can be allergic to excipients in omalizumab itself. I remember it's polysorbate that was contained in the omalizumab constituents. Yeah. So sometimes, we probably it's a good idea to think about other differential diagnoses, such as, being allergic to some other excipients. Yeah.
And I have one more question here. What other pharmacological or no pharmacological options do we have to treat urticaria? Or we will have in a coming future to treat urticaria, hopefully.
Yeah, I guess that you could this answer because only we read the different drugs, proton inhibitors, cyclid H, tepelizumab, but only we read there is a 2 or 3 paper now. But I guess Caroline, I don't know if Jason have this medication or you are involved in different clinical trial.
I think certainly there are quite a few medications in the pipeline. Yeah. So hopefully they'll be available in the near future. I think we're aware there are certain medications that are still being kind of explored. And I'm sure many people in the audience will have read about ligelizumab, which is a higher affinity anti-IgE, which has a binding site that kind of overlaps with omalizumab, and is said to achieve 50 times greater affinity for IgE, and therefore reducing IgE levels greater than omalizumab. That's one of the examples. Other examples that has been explored is dupilumab, which is the cytokine modulator, and it's kind of because it works in such a way that the IgE synthesis is suppressed by inhibition of cytokines like interleukin-4 and interleukin-13 through class switching. And dupilumab, as you know, has been used in asthma, atopic dermatitis, and more recently, chronic rhinosinusitis with nasal polyposis. Other medications on the pipeline, I think benralizumab, anti-IgE, interleukin-5, receptor alpha, monoclonal antibody, and lirentelimab, cyclid-8 inhibitor, and also BTK inhibitor like fevibrutide, remibrutinib. That's all I can remember for now. For the new medications being explored.
But a second, Jason, I'm sorry, Jason, you have an experience to use dupilumab in the urticaria chronica with the patient don't respond to the omalizumab or other treatment?
Not personally, but I have colleagues, who have successfully treated patients, with dupilumab, for a patient who is intolerant of omalizumab.
Yeah, we also have a little experience with dupilumab when either they don't respond to omalizumab, and we've made a good response with or by the patient treating these patients. And like you said, Jason, we have a few new medications on the pipeline. There is also an anti-KIT antibody, which the results on the phase 1 is almost coming to an end, and it looks promising.
You kill off all mast cells.
Yeah, we kill the mast cells, and then we see that the patients don't have any more reactions, at least for a period of 16 weeks. For this study was only one dose that we gave, and it was really good tolerated. It's also been tested for different CINDUs. Cholinergic, cold urticaria, and it looks promising.
That's wonderful news. More options in the future, right?
I guess we have 4 or 5 new options in the future.
Do you also use or indicate omalizumab in CINDUs or only in CSU? So in the inducible urticarias, are you allowed to use CD as well?
It will be a different pathway in where I practice, but it's sometimes you do see patients with CSU with concomitant physical urticaria. In a way, omalizumab would be useful in that regard, and we've used that successfully in treating patients with concurrent dermographism as well.
Guilherme?
Here I have a semi-publication in some time with my team. With then you use on the patient to have the both. You have a chronic urticaria, spontaneous chronic urticaria, inducible chronic urticaria. You have a dermographism. You have a patient that has dermographism and daily pressure and heart urticaria and cold urticaria. You have the fourth, and you we published this in the it's the last year, and all the patients have that provocation before they use omalizumab. We use omalizumab with the time, it's six months, and after that, when enter to remission, we do another provocation for all these patients for the daily pressure, demographism, and cold urticaria and hard urticaria, and all the patients' response to the omalizumab for the both urticarias, like spontaneous urticaria and inducible urticaria. But only the inducible urticaria, we have 2 patients actually used in the hospital today. One patient is a solar urticaria because it's a so hard solar urticaria, and this patient it's a surf person. It's like a beach, like go to the beach, and he creates a depression for that, creates many symptoms for that, and suicide idea and other things, and we introduce omalizumab and have a good response. Today it's a partial response, not good, but for he have a dermographism and solar urticaria. Dermographism remission completely, and solar urticaria sometimes you have more time with the sponsor to the solar, it's more, but the quality of life it's so better, the UCT is so better, the urticaria control test so better, and because that's we continue the omalizumab for this patient, for this solar patient in inducible urticaria. And the professor Solange Valley, it's a coordinator to the department of immunology. We have a patient who use the omalizumab for the cholinergic urticaria with the partial response too. It's not a good response or fast response, but it is a patient response. But it's so interesting when you use OMA in the inducible urticaria, the patients speak for you and tell about the good, the better of the quality of life. It's so important that because in many times in some patients the antihistamine it's not proceeds and not needed all the time, and the patient speak about the cost, about it's so costly, it's so expensive, and the antihistamine is so expensive, it's like 4 doses for a day, and because that omalizumab is so important in inducible urticaria for me, and I have this experience.
I have a question here. In patients that you've been treating, for those patients who have achieved remission on omalizumab, how do you down dose omalizumab?
Professor Eva first, please.
Excuse me, will you repeat the question, please?
Yeah, in your patients who have been successfully treated with omalizumab, or for those patients who have achieved remission or symptomatic control whilst on omalizumab, how do you down dose omalizumab after a period of a treatment?
I treat for 6 months probably, because I would like to treat more. For example, for 1 year, I decrease the dose. It's the best for me, because we are publicated a paper when we're using only 1 dose of omalizumab, we have a good response. But however, we have problem with the money, and we use 6 months. After that, we continue using sometime antihistamine, but we look what all of the months patient-reported outcomes, and we know for each patient how move this kind of the severity. Okay, for example, if we are looking at some subdomains of quality of life are increasing, we call our patient and we put 1 or 2 doses of omalizumab. And in our experience, we know that approximately the people have the benefits of omalizumab for 2 months or maximum 3 months. After 3 months, our patient needs 1 more dose, and we are waiting for the pen 3 months too, and we continue. That is our experience.
Okay, thank you.
Here in the hospital, and we sponsor the time and for 4 and 4 weeks, and after that 6 and 6 weeks, and after that 8 and 8 weeks, and after that 10 and 10 weeks. And if the patient creates a good remission, we can stop it, the omalizumab, and the patient continues continues in the hospital, continues to the consult and the ambulatory, but not more omalizumab. If the patient, if the disease return, you can introduce anymore another time omalizumab after that. But you use like a low dose, like 6 and 6 weeks, and low dose antihistaminic too. And for the 40 and like that 2 doses per day, and after that 1 dose per day, and after that you can space or distance to the dose of omalizumab.
Yeah. In our sorry.
No,
in our local setting, because when we start a script for omalizumab, we are given 6 months access. After 6 months, we can renew for another script for 6 months. So technically, many patients will stay on omalizumab for 12 months, which is completion of 1 year. And after that, if the patient is in remission, we tend to stretch out the doses, extend the interval from 4 weekly to 6 weekly for a few doses. If that all goes well, we can extend the interval for even longer duration, like for example, 8 weekly or 9 weekly, and see how and reassess a patient. Yeah.
Thank you, Jason. I will send my patient to your country. And one question for the group. When you have obese patient, you don't think that this kind of patient probably need more omalizumab, more dose? Do you have experience with this kind of patient? Only with obese patient?
Yes, that's a good question because of the density of the adipose tissue. Yeah, that makes you wonder about the concentration reaching the plasma. Yeah.
Yeah, because I guess when you have a obese patient, omalizumab is probably don't function. We need to increase in this kind of patient 1 more syringe.
Yes, that's a very good point. Yeah.
And I have a question for the group too. What do you use what to do when a non-pharmacological treatment for urticaria, spontaneous urticaria, and for other inducibles? Inducibles, you can cholinergical. It's not food, hard food, and you reduce the exercise and frequency and intensity. Solar, you can utilize the shirt. But what do you want? What you do in your patients today?
So, sorry, as in avoidance of triggers, you mean?
Yes, for the triggers. And if you use a menthol, if you use a thing for the eating or for the swelling, the patient, what you do in the patient with the chronic urticaria or induced urticaria, the both.
Yeah, I guess it comes.
Yeah, I can use your experience for that.
Yeah, I guess it all comes down to modifiable risk factors. For example, if the urticaria or physical urticaria is induced or exacerbated by friction of clothing, probably wearing loose clothing might be one way to address the issue. Yeah, as an example. Yeah.
Professor Van, what do you do?
It's the same with some time. We have more another kind of treatment, but we don't have time, and probably we have a lot of discussion because I in the next part, in the next conversation we talk about this, or I invite you to the Gulf in December and we talk about this.
All right. I guess it's about time to close the session. We are close to our 1 hour discussion mark. So I would like to take this opportunity to thank everyone in the audience for your active participation and raising questions as well. So I think to summarize the discussion today, we talk about different treatment options in treating CSU, as well as CINDU, includes antihistamine, omalizumab, cyclosporine, Dapsone, hydroxychloroquine, and then we talk about new treatments on the horizon, and many of them are still being explored at the moment. And also we talk about duration of treatment, duration for omalizumab, cyclosporine, and how do we down-dose or up-dose the treatment plan according to the severity of the patients. Lastly, I think we also covered potential side effects arising from different medications, such as cyclosporine or omalizumab. And I guess that's probably all. Yeah. Anyone else have anything to add? Anything that I've missed? If not, I think we can close the session today.
Yeah, maybe just put again the QR code so that you do an evaluation or of how we were and if you really like the team and the discussion. Thank you very much for the discussion.
Thank you, everyone. Yeah,
really nice.
Enjoy the morning, afternoon, or evening, wherever you are.
Thank you for
thank you for the invitation. I enjoy this conversation with all of the faculty. Thank you for inviting me to the discussion.
It's same for me. Thank you for the invitation. Thank you for all the discussion and learning in this morning in the South America.
We learn a lot. Goodbye.
Goodbye. Thank you.
Bye-bye.